Hi, my name is Sindra, and I will soon be starting my investigation project for the Speech-Language Pathology Clinical Doctorate Program at Rocky Mountain University of Health Professions. Here's my research question. In otherwise healthy adults with diagnosed or suspected laryngopharyngeal reflux, LPR, does adherence to a low-acid whole foods diet, specifically the 28-day healing phase outlined in Dr. Jonathan Aviv's book, The Acid Watcher Diet, result in measurable decreases in LPR symptoms and edematous laryngeal mucosa, compared to participants' stable baseline measures? Claim. I believe that the dietary changes will significantly positively impact participants' self-reported symptom severity, as well as have positive physiological changes in their laryngeal mucosa. A non-concurrent baseline variation allows for treatment to start at delayed intervals and is the reason I plan to use the non-concurrent multiple probe across participants design to allow more flexibility with participant recruitment. My goal is to find 5 or more participants that are otherwise healthy community-dwelling adults with diagnosed or suspected LPR. Patients must score higher than 13 on the reflux symptom index and greater than 6 for females or 9 for males on the reflux finding score. Participants will be excluded if they have diabetes, irritable bowel syndrome, celiac disease, multiple food allergies, or have other dietary restrictions and/or reactions that would preclude them from following the low-acid diet protocol. Participants may also be excluded during the study if they fall below 80% adherence with the intervention. I plan to have 2 dependent variables. First, participants' self-reported laryngopharyngeal symptoms as measured by the reflux symptom index, and second, the laryngeal tissues visualized by endoscope as measured by the reflux finding score. Because LPR shares many common symptoms with other problems such as hoarseness and chronic cough, these 2 measures are often used together to differentially diagnose laryngopharyngeal reflux, and therefore is the reason I would like to consider both dependent variables in my investigation. The independent variable will be implementation of the 28-day healing phase of the Acid Watcher diet outlined by Dr. Jonathan Aviv. In a nutshell, this intensive healing phase does not allow late-night eating and eliminates items known to exacerbate reflux, such as caffeine, chocolate, alcohol, and smoking. And the hallmark of this diet is that only foods with a pH level of 5 or higher are allowed during the 28-day healing phase. Using a non-concurrent multiple probe baseline means that I will need to predetermine various baseline lengths and randomly assign these baseline lengths to each participant. My baseline lengths will be 5, 10, 15, 20, and 25 days, and these will be randomly assigned to each of the 5 participants. Because I hope to work in conjunction with an ENT physician for recruiting participants, this will allow flexibility in the recruitment process, making it easier for the physician to identify and refer potential participants for this study. Once the participant has been randomly assigned a baseline length, probes will be completed at the beginning, middle, and end of the baseline timeframe. Baseline RSI and RFS measures will be taken, and participants will be excluded if any baseline measures fall below the cutoff scores. Let's look at the measurement tools. The Reflux Symptom Index is a 9-item self-administered questionnaire designed to document LPR, laryngopharyngeal reflux, symptoms, and severity. It uses a 0 to 5 Likert scale, with 0 indicating no problem and 5 indicating a severe problem. Questions include 1. Hoarseness or problem with your voice, 2. Clearing your throat, 3. Excess mucus or postnasal drip, 4. Difficulty swallowing food, liquids, or pills, 5. Coughing after you eat or after lying down, 6. Breathing difficulties or choking episodes, 7. Troublesome or annoying cough, 8. Sensation of something sticking in your throat or a lump in your throat, and 9, heartburn, chest pain, indigestion, or some stomach acids coming up. A maximum total score of 45 is possible, with 13 considered positive for suspected LPR. The reflux finding score is an 8-item index designed to assess clinical severity based on endoscopic findings. Scores range from 0, normal, to 26, most severe, with gender-specific cutoff scores, greater than 9 for males and greater than 6 for females, indicating the presence of LPR. The 8 items include 1, subglottic edema, 2, ventricular obliteration, 3, erythema, hyperemia, 4, vocal fold edema, 5, diffuse laryngeal edema, 6, posterior commissure hypertrophy, 7, granuloma, granulation, and 8, thick endolaryngeal mucus. The RSI and RFS have been shown to closely correlate with each other, as well as with more sophisticated pH monitoring for detecting patients with LPR. Also, during treatment for LPR, the RFS and the RSI are also highly correlated with pH monitoring regarding remission values as patients' problems resolve with treatment. So in a nutshell, the RFS and the RSI are sensitive in both identifying LPR and also measuring treatment effectiveness. This is why I plan to use the RFS and RSI as tools to identify patients who are suspected positive for LPR, and also to measure symptom and tissue changes as the low-acid diet is adhered to during the 28-day intervention period. Participants will be provided with the Acid Watcher Diet book by Dr. Aviv, pH strips for identifying food acidity, quick reference food pH charts, recipes and meal plans, restaurant guides, and a food journal. Patients will be asked to keep a food journal, which I plan to review during the 4 weekly check-in meetings. At these weekly check-in meetings, not only will I review the food journals to ensure greater than 80% adherence to the diet protocol, I will also administer the RSI and complete an endoscopic evaluation for the reflux finding score. To increase reliability of measures, RFS scores will be peer-reviewed. In 2011, Dr. Jamie Kaufman did a similar investigation with 20 participants over a 2-week period. Her investigation was more simple, focusing only on foods with a pH above 5. She did not restrict other behaviors such as smoking or mealtime. Dr. Aviv's diet requires eating only 3 meals and 2 snacks, and not eating after 7:30 p.m. Dr. Kaufman anticipated that the symptoms, measured by the RSI, would resolve more quickly and dramatically than the laryngeal mucosa findings of the RFS. Her results showed significant changes in both measures, with, as expected, more dramatic improvements in the RSI or symptom scores. I anticipate similar findings with the symptoms resolving more quickly than the changes in the mucosal tissue. This graph shows sample data for 3 participants. You can see the varying baseline lengths here with the 3 baseline measures taken at the beginning, middle, and end of the baseline period. The dashed green line indicates the point at which their scores fall below the cutoff and into the normal range. I anticipate reaching the goal line sooner with RSI symptom scores than RFS measures. Although the participants may reach the goal of subclinical scores early in the intervention, I plan to continue with the intervention phase for the predetermined 28 days to help determine the full effect of Dr. Aviv's proposed 28-day healing phase and plan to compare the average mean pre- and post scores. Speech-language pathologists are increasingly seeing patients for esophageal swallowing problems and are limited with therapy tools to help patients address this. LPR has a high rate of medical treatment failure, and as doctors with large caseloads and tight schedules often don't have the time to help patients succeed through the difficult process of making dietary changes. Esophageal adenocarcinoma has increased 600% since 1975, and during this same time period, the mortality rate increased 7-fold. Esophageal cancer is often not detected until it's in the advanced stages when patients are complaining of swallowing problems. When patients present with advanced adenocarcinoma, they are often dead within a year of the diagnosis. The 5-year survival rate is 15%. LPR is a precursor to Barrett's esophagus, where tissues mutate due to frequent exposure to high acidity reflux. When our tissues attempt to change, there's a chance something's going to go wrong in this mutation process. And this is why Barrett's esophagus is a significant precursor to esophageal adenocarcinoma. As the food is medicine movement matures, I believe SLPs can use dietary interventions with our patients as effective tools to help patients with vocal hoarseness, chronic cough, globus sensation, and swallowing difficulties. Unlike physicians, we often have the luxury of seeing our patients on a routine and frequent basis, which is the type of intervention often needed to make changes to such ingrained behaviors like food choices and eating habits. Not only will this intervention help with our patients' immediate voice and swallowing symptoms, but may also result in life-changing behaviors that will significantly reduce their risk for deadly esophageal adenocarcinoma. LPR is increasingly common and is being seen in increasingly younger populations each year. Common symptoms of LPR include vocal hoarseness, chronic cough, excessive throat clearing, breathing difficulties, choking episodes, lump in the throat sensation, and difficulty swallowing. Symptoms that are commonly referred to SLPs for treatment. When the cause of these symptoms is underlying LPR, our standard therapy approaches will not be very effective. For my investigation, I would like to explore the effectiveness of a low-acid dietary intervention with participants with LPR to determine if this intervention may be effectively and successfully used by SLPs with this population.